Welcome to MRCpology channel for quick review, understanding of the topics, and a stepwise approach to the PACES exam. Tremor is a rhythmic, involuntary oscillation of a body part. It is produced by alternating or synchronous contraction of agonist and antagonist muscles. It causes repeated movement around the same joint or body axis, which helps distinguish it from many other movement disorders. The key first step is to classify the tremor according to when it occurs. Ask whether it is present at rest, while maintaining a posture, during voluntary movement, near a target, or only during a specific task. Before going further, quickly revise our neurology prerequisite video on this YouTube channel. Normal movement depends on the motor pathway and three important control systems. The first control system is the basal ganglia. These structures lie deep within the brain. They help select and initiate the desired movement while suppressing unnecessary competing movements. Basal ganglia dysfunction may suppress desired movement, producing bradykinesia. It may also allow unwanted movements, producing tremor, chorea, or dystonia. The second control system is the cerebellum. Through the Cerebellothalamocortical pathways, the cerebellum compares the movement intended by the cerebral cortex with the movement that is actually occurring. It adjusts the force, timing, direction, and range of movement. Cerebellar dysfunction causes inaccurate correction. The limb may undershoot or overshoot the target. This is called dysmetria. Repeated corrective movements can then produce an intention tremor. The third component is sensory feedback. This is provided mainly by proprioception, the vestibular system, and vision. Proprioception informs the brain about the position of the limbs and joints. The vestibular system provides information about head position, movement, and balance. These inputs are integrated, particularly by the cerebellum, to maintain posture, balance, and coordinated movement. Loss of proprioceptive feedback may therefore cause sensory ataxia and imbalance. Now let us understand the pathophysiology of tremor. Tremor usually reflects abnormal oscillation within one or more motor control loops. First, consider the cerebellothalamocortical loop. The cerebellum communicates with the thalamus and motor cortex. Dysfunction within this loop produces action or intention tremor. Impaired error correction leads to repeated undershooting and overshooting. The oscillation becomes more obvious as the limb approaches the target. Second, consider the basal ganglia loop. In Parkinson's disease, loss of dopaminergic neurons in the substantia nigra alters basal ganglia output. This produces abnormal rhythmic activity within the basal ganglia thalamocortical network and contributes to rest tremor. Third, consider peripheral and mechanical oscillation. Maintaining a posture requires continuous low-level activity in agonist and antagonist muscles. This produces a very small physiological tremor, which is normally not visible. Anxiety, fatigue, caffeine, thyrotoxicosis, hypoglycemia, certain drugs, and increased beta-adrenergic activity can amplify this normal oscillation. It then becomes an enhanced physiological tremor. In essential tremor, the exact mechanism is not fully understood. It is thought to involve abnormal oscillation within cerebellar networks rather than being a pure basal ganglia disorder. This usually produces a bilateral postural and action tremor. Some patients report temporary improvement after alcohol, but this is not universal and should not be used as a diagnostic test. The core clinical approach is therefore simple. Classify the tremor according to its activation condition and then link it to the motor circuit most likely to be producing the oscillation. A rest tremor occurs when the affected body part is fully supported and not voluntarily activated. Ask the patient to relax their hands on their lap. Observe from different angles. Mental activation, such as asking the patient to count backwards, may make a subtle tremor more visible. A rest tremor is classically associated with Parkinson's disease. Dopamine loss alters basal ganglia output and produces abnormal rhythmic activity within the motor network. The tremor typically reduces during voluntary movement, although it may reemerge after the patient maintains a posture for several seconds. It is often asymmetrical, relatively slow at around 4 to 6 Hz, and may have a pill-rolling appearance. Do not diagnose Parkinson's disease from tremor alone. Look for bradykinesia, rigidity, reduced arm swing, hypomimia, a quiet voice, and difficulty turning. By this stage of the examination, these associated findings should already be contributing to your clinical impression. In PACES, you could say, there is an asymmetrical rest tremor, which attenuates with voluntary movement and is associated with bradykinesia and rigidity, suggesting Parkinsonism. A postural tremor appears while the patient maintains a position against gravity. Ask the patient to stretch both arms forwards, spread the fingers, and hold the position. Observe the fingers and hands. A sheet of paper placed across the hands may reveal a subtle, fine tremor. Maintaining posture requires continuous motor unit activity. An enhanced physiological tremor occurs when normal peripheral oscillations are amplified by anxiety, fatigue, caffeine, thyrotoxicosis, hypoglycemia, beta-adrenergic drugs, or other medications. It is usually fine, fast, bilateral, and relatively symmetrical. Essential tremor also commonly appears during posture. It is usually bilateral and affects the upper limbs. It may also affect the head or voice. The tremor is often more obvious during movement and may interfere with writing, drinking, or eating. In PACES, you could say there is a fine bilateral postural tremor. I would consider enhanced physiological tremor, essential tremor, medication effects, and thyrotoxicosis, depending on the associated clinical features. An action or kinetic tremor occurs during voluntary movement. Ask the patient to drink from a cup, pour water, use a spoon, write a sentence, or draw an Archimedes spiral. These tasks demonstrate the functional impact of the tremor. In essential tremor, abnormal timing within cerebellar motor networks produces rhythmic oscillation during goal-directed movement. The tremor is usually bilateral and may worsen with stress or fatigue. A task-specific tremor appears mainly during one particular activity, such as writing or playing a musical instrument. Examine for abnormal posturing because some task-specific tremors are associated with dystonia. An intention tremor is a form of kinetic tremor that becomes increasingly severe as the limb approaches a visual target. Demonstrate it using the finger-nose test. Ask the patient to touch their nose and then your finger repeatedly. Move your finger to different positions. A cerebellar lesion impairs feed-forward control and error correction. The limb repeatedly overshoots and undershoots the target. The oscillation therefore increases near the target. This is often accompanied by dysmetria, decomposition of movement, dysdiadochokinesia, hypotonia, nystagmus, scanning dysarthria, or a broad-based gait. By this stage, the examination may already have identified other cerebellar signs. The finger-nose test confirms and consolidates the impression that the tremor is caused by impaired cerebellar coordination rather than basal ganglia dysfunction. Important causes include multiple sclerosis, cerebellar stroke, tumor, and alcohol-related cerebellar degeneration. The clinical context helps separate them. Acute onset suggests a vascular lesion. Multiple neurological episodes separated in time and affecting different parts of the nervous system in a younger patient may suggest multiple sclerosis. Progressive focal signs require investigation for a structural lesion. To understand these causes better, quickly revise our videos on cerebellar syndrome, multiple sclerosis, and neurological localization on this YouTube channel. In PACES, you could say, there is a crescendo intention tremor with dysmetria, suggesting dysfunction of the ipsilateral cerebellar hemisphere or its connections. A dystonic tremor is usually irregular and jerky. It occurs in a body part affected by abnormal posture or sustained muscle contraction. Dysfunction within basal ganglia cortical motor networks causes excessive co-contraction and abnormal positioning. The tremor may be position-specific and may reduce when the patient lightly touches a particular area. This improvement with light touch is called a sensory trick. Look carefully for abnormal neck posture, wrist deviation, finger posturing, or hypertrophy of overactive muscles. An isolated irregular head tremor associated with abnormal neck posture should raise suspicion of cervical dystonia rather than essential tremor. In PACES, you could say, there is an irregular, position-dependent tremor associated with dystonic posturing, suggesting a dystonic tremor. A functional tremor is characterized by variability, distractibility, and entrainment. Its frequency or amplitude may change during the examination. It may reduce when attention is diverted. It may also adopt the rhythm of voluntary tapping performed by another limb. This is called entrainment. Functional tremor reflects altered control of movement and attention. It is genuine and is not the same as deliberately producing symptoms. The diagnosis should be based on positive clinical signs rather than simply on normal investigations. In PACES, you could say, the tremor demonstrates variability, distractibility, and entrainment, which are positive features of a functional tremor. The diagnostic approach should remain systematic. First, identify the activation condition. Decide whether the tremor occurs at rest, during posture, during voluntary movement, near a target, or during a specific task. Second, identify the distribution. Determine whether it is unilateral or bilateral and whether it affects the hands, head, voice, jaw, trunk, or legs. Third, assess the frequency and amplitude. A fine, fast tremor suggests enhanced physiological tremor. A slower, coarser rest tremor may suggest Parkinsonism. However, frequency alone is not diagnostic. Fourth, look for associated neurological signs. Bradykinesia and rigidity suggest Parkinsonism. Dysmetria, nystagmus, dysarthria, and a broad-based gait suggest cerebellar dysfunction. Abnormal posture suggests dystonia. Peripheral neuropathy or loss of joint position sense may indicate impaired sensory feedback. Fifth, review triggers and medications. Important examples include salbutamol, lithium, sodium valproate, selective serotonin reuptake inhibitors, antipsychotic drugs, amiodarone, and excessive caffeine. Prescribed medication should not be stopped without appropriate clinical review. Sixth, consider systemic causes. Investigations should be guided by the history and examination. They may include thyroid function tests, blood glucose, renal function, liver function, calcium, and vitamin B12. Look for red flags. Acute onset may indicate stroke, drug toxicity, or a metabolic disturbance. Focal neurological signs or cerebellar signs require urgent localization and appropriate imaging. Rapid progression suggests a structural, toxic, inflammatory, metabolic, or degenerative cause. In a younger patient with tremor, dystonia, liver disease, psychiatric symptoms, or unexplained neurological deterioration, consider Wilson disease. Look for Kayser-Fleischer rings and arrange appropriate copper studies with specialist input. Treatment depends on the underlying cause and the degree of functional impairment. For enhanced physiological tremor, identify and remove the trigger where possible. Address anxiety, fatigue, excessive caffeine, hypoglycemia, thyrotoxicosis, or causative medication. A beta blocker may be considered in selected patients when the tremor is functionally troublesome and there are no contraindications. Beta blockade reduces peripheral adrenergic amplification and therefore reduces tremor amplitude. For essential tremor, first-line drug options include propranolol and primidone. Propranolol reduces beta adrenergic amplification of the tremor. Primidone reduces neuronal excitability and dampens oscillation within motor networks. Treatment is generally considered when the tremor causes functional or social impairment. Contraindications and adverse effects must be considered before prescribing. For Parkinsonian tremor, dopaminergic treatment such as levodopa may reduce the tremor when it is functionally significant. Restoring dopaminergic signaling improves basal ganglia output and reduces abnormal motor network activity. The response of tremor can be variable, so management should consider the complete Parkinsonian syndrome rather than the tremor alone. For intention or cerebellar tremor, treat the underlying cause. This may involve management of multiple sclerosis, stroke, a structural lesion, toxicity, or nutritional deficiency. The response to symptomatic medication is often limited because the cerebellar timing and error correction circuits are structurally damaged. Physiotherapy, occupational therapy, and practical adaptations may improve function. For dystonic tremor, botulinum toxin can be useful when the tremor is focal. It weakens selected overactive muscles, reducing abnormal co-contraction, dystonic posture, and tremor amplitude. The memory hook is activation, distribution, associated signs, triggers, and systemic causes. First, ask when the tremor appears, then ask where it appears. Next, look for the neurological syndrome surrounding it. Finally, search for reversible triggers and important underlying disease. Do subscribe to the channel for further videos.